ESR1 mutations are an acquired resistance mutation to endocrine therapy, primarily aromatase inhibitors. And they typically develop after at least 6 months of exposure to aromatase inhibitors or endocrine therapy. However, we see that the emergence of the ESR1 mutation is more likely a little later on in the disease course, closer to about 2 years after exposure to endocrine therapy. The incidence at time of progression on patients after first-line therapy can be upwards of about 40% emergence of an ESR1 mutation. And what that mutation is essentially doing is it is activating the estrogen receptor such that the disease becomes resistant to aromatase inhibition. And so I think where we're kind of heading in the field is if we're able to identify the emergence of this resistance mechanism, is there a way in which we can target that resistance earlier on to resensitize the disease to endocrine therapy and subsequently prolong the course that patients have stability of their cancer on these agents?
Great. You outlined the problem very well. So, Reshma, what do you think about the approach? Are you testing? Well, let's take a step back. When are you doing next generation sequencing for your patients? Early stage, metastatic stage, at what point in metastatic disease? And what kind of panels are you using? Are you testing specifically for the ESR1 mutation? Just walk us through your testing strategy.
Sure. So starting off in the early stage setting, I haven't routinely incorporated the use of ctDNA. I know there's a lot of interest in it. I always tell my patients it's coming, but we're not there yet. We do know that it's a very sensitive tool that's prognostic, but of course our challenge in the early stage setting is how to intervene and if we can change the clinical course. In the metastatic setting, we talked about the importance of doing NGS testing at initial diagnosis, and it's standard to biopsy for tissue confirmation, reconfirm ER, PR, HER2. And also now we have the target that we discussed with the use of inavolisib. In the setting of progression, it's really important to continue to check for emergence of mutations, specifically ESR1 mutations that are best captured on liquid biopsies, as some of these mutations are subclonal, meaning if you checked it on a liver biopsy, you might see it, you might not see it on a lung specimen. So liquid biopsies better capture the heterogeneity of the disease. And as Manali pointed out, up to 40 to 50% of tumors acquire this ESR1 mutation with subsequent lines of therapy.